I'd like to explain the normal anatomy of the heart. First of all, I'd like to show you the external anatomy and coronary artery anatomy and internal anatomy of the heart. It's basically very simple for most cardiologists. So this is just reminding your knowledge on cardiac anatomy. If you look at from the close up this heart first. If you look at the heart from the front, you can see pulmonary trunk in the front, and the ascending aorta is right posterior to the pulmonary trunk. On the right side, you can see the right atrium and superior vena cava, and there is a diaphragm under here. And there, with an apex of pulmonary trunk, we can see a triangular shape of right ventricle, and the left ventricle is shown on the left side of this ventricle. And between them, we can see the coronary artery, left anterior descending coronary artery over here. If you look at from the right side, we can see much better the shape of right atrium, having triangular shape of right atrium, and also we can see the superior vena cava as a structure of a vessel rather than myocardium. So it's and there is a groove between at the junction between superior vena cava and right atrium, which is a terminal groove or sulcus terminalis, which is an external landmark for sinus node over here. And then there is a ascending aorta between pulmonary trunk and superior vena cava. And if you show the lifted up the right atrial appendage, we can see the space between aorta and rest of the atrium, so that the aorta and pulmonary trunk has a common pericardium, whereas they are separated from the rest of the atrium as a transverse pericardial sinus. And then in this groove, the atrioventral groove on the right side, there is a right coronary artery running within the fatty tissue and surrounding the tricuspid valve. If you look at the same heart from the left side, we can see pulmonary trunk going back to the left pulmonary artery and right pulmonary artery behind the ascending aorta. In this case, the left atrial appendage is removed to show some details of origin of left coronary artery, to show the left coronary artery arises from the ascending aorta as a common branch, a very short common branch, and left anterior descending and left circumflex artery. Here, it's not easily possible to demonstrate a coronary sinus, but there is a coronary sinus running in the same direction with the coronary artery at this left atrial ventricular junction. In the back, inferior aspect of the heart, we can see the opening orifice of inferior vena cava and pulmonary veins to the left atrium, and then we can see the junction between right and left atrium, which we call Waterston groove. And this vertical junction is crossing the atrioventricular junction at the right side and left side. So this area, the junction between atrial septum and atrioventricular groove, is the so-called crux cordis. Again, this is usually in the normal heart has a same alignment with the ventricular septum, so that posterior descending coronary artery is running around here to make the real crossing these two atrial ventricular septum and mitral and tricuspid valve together. And then we can realize that the coronary arteries are really delimiting, locating structure for those divisions. So in this heart, we put some resin to the ascending aorta, so that coronary arteries are filled and then I removed the fatty tissue to demonstrate the size and direction and presence of coronary arteries. In this side, this is again pulmonary trunk, ascending aorta, and in here right coronary artery is arising from the right coronary artery, running between right atrium and right ventricle on right atrioventricular groove, which is right coronary artery. It has an infundibular branch like this, and then there is this border is acute border, acute marginal artery this artery is named as acute marginal artery. If you go further, we can see the continuation of right coronary artery to posterior descending coronary artery, which is the marker of ventricular septum. At this particular point, we can see a significant branch going in front anterosuperiorly from this right coronary artery, which is directing to AV node, which is here. So this coronary artery is AV nodal artery to go there. There exists the presence of coronary artery in this posterior interventricular groove and anterior interventricular groove means that there is a demand for blood supply at the septal area so that the blood can easily go to the septal area. And then from the left side, as we can see, there is a very short common coronary artery, and then left artery descending coronary artery, left circumflex artery. There is a first diagonal branch at the oblique direction from the left coronary artery, anterior descending coronary artery. So the first diagonal branch, second, third diagonal branch is here, and so on. Left circumflex arteries usually disappears around here, and this obtuse margin, blunted margin of the left ventricle make obtuse margin artery. I put the resin in darker color to show the cardiac vein, so that there is a coronary sinus here draining most of the cardiac veins from the left ventricle. If you are interested in to see the sinus nodal artery, we can define the pathway in this view. So there is a superior vena cava. This is superior vena cava. So sinus node is here. So it's there is a transfer cortical sinus, and this particular area is close to either from here or here. In this case, there is a sinus nodal. Good afternoon. I'd like to explain the normal anatomy of the heart. First of all, I'd like to show you the external anatomy and coronary artery anatomy and internal anatomy of the heart. It's basically very simple for most cardiologists. So this is just reminding your knowledge on cardiac anatomy. If you look at from the close up this heart first, if you look at the heart from the front, you can see pulmonary trunk in the front, and the ascending aorta is right posterior to the pulmonary trunk. On the right side, you can see the right atrium and superior vena cava, and there is a diaphragm under here. And there, with an apex of pulmonary trunk, we can see a triangular shape of right ventricle, and the left ventricle is shown on the left side of this ventricle. And between them, we can see the coronary artery, left anterior descending coronary artery over here. If you look at from the right side, we can see much better the shape of right atrium, having triangular shape of right atrium, and also we can see the superior vena cava as a structural vessel rather than myocardium. So it's and there is a groove at the junction between superior vena cava and right atrium, which is terminal groove or sulcus terminalis, which is an external landmark for sinus node over here. And then there is a ascending aorta between pulmonary trunk and superior vena cava. And if you show the lifted up the right atrial appendage, we can see the space between aorta and rest of the atrium, so that the aorta and pulmonary trunk has a common pericardium, whereas they are separated from the rest of the atrium as a transverse pericardial sinus. And then in this groove, the atrioventral groove on the right side, there is a right coronary artery running within the fatty tissue and surrounding the tricuspid valve. If you look at the same heart from the left side, we can see pulmonary trunk going back to the left pulmonary artery and right pulmonary artery behind the ascending aorta. In this case, the left atrial appendage is removed to show some details of origin of left coronary artery, to show the left coronary artery arises from the ascending aorta as a common branch, a very short common branch, and left artery descending and left circumflex artery. Here, it's not easily possible to demonstrate a coronary sinus, but there is a coronary sinus running in the same direction with the coronary artery at this left atrial ventricular junction. In the back, inferior aspect of the heart, we can see the opening orifice of inferior vena cava and pulmonary veins to the left atrium, and then we can see the junction between right and left atrium, which we call Waterston groove. And this vertical junction is crossing the atrioventricular junction at the right side and left side. So this area, the junction between atrial septum and atrioventricular groove, is the so-called crux cordis. Again, this is usually in the normal heart, has a same alignment with the ventricular septum, so that posterior descending coronary artery is running around here to make the real crossing these two atrial ventricular septum and mitral and tricuspid valve together. And then we can realize that the coronary arteries are really delimiting, locating structure for those divisions. So in this heart, we put some resin to the ascending aorta, so that coronary arteries are filled, and then I removed the fatty tissue to demonstrate the size and direction and presence of coronary arteries. In this side, this is again pulmonary trunk, ascending aorta, and in here right coronary artery is arising from the right coronary artery, running between right atrium and right ventricle on right atrioventricular groove, which is right coronary artery. It has an infundibular branch like this, and then there is this border is acute border, acute marginal artery this artery is named as acute marginal artery. If you go further, we can see the continuation of right coronary artery to posterior descending coronary artery, which is the marker of ventricular septum. At this particular point, we can see a significant branch going in front anterosuperiorly from this right coronary artery, which is directing to AV node, which is here. So this coronary artery is AV nodal artery to go there. There exists the presence of coronary artery in this posterior interventricular groove and anterior interventricular groove means that there is a demand for a blood supply at the septal area, so that the blood can easily go to the septal area. And then from the left side, as we can see there is a very short common coronary artery, and then left artery descending coronary artery, left circumflex artery. There is a first diagonal branch at the oblique direction from the left coronary artery, anterior descending coronary artery. So the first diagonal branch, second, third diagonal branch is here, and so on. Left circumflex arteries usually disappears around here, and this obtuse margin, blunted margin of the left ventricle make obtuse margin artery. I put the resin in darker color to show the cardiac vein. So there is a coronary sinus here draining most of the cardiac veins from the left ventricle. If you are interested in to see the sinus nodal artery, we can define the pathway in this view. So there is a superior vena cava. This is superior vena cava. So sinus node is here. So it's there is a transfer cortical sinus, and this particular area is close to either from here or here. In this case, there is a sinus nodal artery arising left main coronary artery to go through the wall to supply sinus nodal artery. If you open the heart, we can see most of the structure of the atrial chambers and ventricles and so on. So in this heart, there is it's not very good specimen, so it's not easy to see everything at this time, but we can see in this septal surface with relatively flat internal surfaces, and also atrial appendage structure with pectinate muscles around here. And then there is a junction, the external junction between the smooth area to the pectinate trabeculated area. Yeah, please. Yeah. So you can just enjoy. Yeah. And here is the external junction between sinus venosus. This is superior vena cava, and those continuous area with a flat external surface is sinus venosus or sinus venarum, which internally it is a really continuation of vascular structure to the atrial side, which is divided by this terminal groove and internally terminal crest to make a division from those area with pectinate muscle and those without pectinate muscle. So the septal surface here is that fossa ovalis is here, and thank you. And here is the orifice of coronary sinus. We know that there is a Tevesian valve nodules in this area, which is produced because they are the point of point of contact. Contact point, so that they have nodules like this, and so it's a line of closure. So when this valve close, they are the meeting more than 8 or 9, 80 times in a month, in a week, in a minute. So they have very strong nodules, so that so this particular area is very important for the attachment of vegetation in rheumatic heart disease and so on. So having this anatomy with fine and delicate the chordae and papillary muscle in this structure is very well organized, but in those diseased valve, we can see scarring of this leaflet, particularly at those area of contact point. And then we can see the left ventricle having two major pulmonary muscles at the free wall side, but this we can see in the apex the fine trabeculation and absence of any attachment of valvular tissue at the septal surface, which is different from septal leaflet of tricuspid valve. And this is the aortic valve, and there's this part is membranous septum, and mitral anterior leaflet and non-coronary cusp of aortic valve has fibrous continuity without any interposing muscular structure between them. And we can see the coronary artery orifice here, so that right coronary artery is here and left coronary artery is here. So and aortic valve is different from the mitral or tricuspid valve. Aortic and pulmonary valve both together are different from atrioventricular valve, so that in atrioventricular valve there is a single annular structure at the annulus with tension apparatus, but in this arterial valve they have a valve leaflet having every function aligned together, so that there is a supra-aortic ridge having the level of commissural attachment and aortic ring below the end of individual cusp, so that there is a semilunar attachment, and this is a kind of pocket-shaped leaflet to make these three leaflet meets without any leakage and without any papillary muscle or chorda. And so this is the internal anatomy of heart.
So this is the external surface of the heart, and which you just saw now. And you can see that this is the left anterior descending, which demarcates the right ventricle from the left ventricle. And you can see the great arteries. This is the left and anterior pulmonary artery as against right and posterior aorta. Now we can start from the right atrium. And you can see that this is the opened up right atrium. Sorry. And you can see that it's just a marginally hypertrophied wall of the right atrium. And this is the septal surface of the right atrium. And then you can see the tricuspid valve. And then you can see the opened up right ventricle here. Here is the opened up right ventricle, and you can see the wall of the right ventricle also shows hypertrophy, which is, as you know, characteristic of a heart with a tetralogy like physiology. Now you look at the ventricular septal defect. This patient has been operated, so you can see the patch which has been now opened up. So this particular characteristic of the ventricular septal defect, this is very, very constant, irrespective of whether you have a tetralogy with pulmonary stenosis or tetralogy with pulmonary atresia. It lies between the two limbs of trabeculoseptomarginalis. The antero-superior limb is here, and the postero-inferior limb is here. And this is the septal trabeculation. And you will see that although in a normal heart, you are not able to see the outlet septum or the infundibular septum as a separate part. In a patient with tetralogy, you will find that the infundibular septum would come a little more anteriorly and cause a malalignment. Unfortunately, I think in this specimen probably it has been chopped off. So we are not able to see because this is a repaired tetralogy of fallow. Otherwise, you will be able to see the infundibular septum which comes antero-superiorly. And that is why, if you remember that article from Van Praag, he said that it's a monology and not a tetralogy, where the outlet septum moves antero-superiorly, producing right ventricular outflow tract obstruction, producing a malaligned or a conoventricular ventricular septal defect, aortic override, and right ventricular hypertrophy. So it's a single morphological abnormality which causes this particular problem of tetralogy. Now let's look at the pulmonary annulus and the branch pulmonary arteries. So, yeah, so this is the pulmonary artery, and probably these are the two branches of the pulmonary artery. This is the right pulmonary artery, that's the left pulmonary artery, and this is the main pulmonary artery. I mean, in this particular case, I think the pulmonary artery size is reasonably good. So, and this probably is the transannular patch which has been.
This is also graft.
Oh, this is a graft?
Yeah, so native structure is only here.
Oh,
so,
okay.
Yeah, yeah.
So this is probably the graft which has been put from the right ventricle onto the pulmonary arteries.
Yes.
I'm sorry.
Yeah.
So this probably was a case of tetralogy of Fallot with pulmonary atresia, and that may be one of the reasons why we are not able to see the infundibular septum at all. So the entire right ventricular outflow tract was probably atretic, and that is the reason why they have grafted from the right ventricle into the pulmonary artery branches. So now we will see another specimen, and you can see again here the external surface of the heart, and you can see that this is the pulmonary artery which is anterior and to the left, and you can see that this is the aorta which is lying posterior and to the right, and this is the atrioventricular groove here, and you can see the right atrial appendage just behind the ascending aorta. And this is the right ventricle, which you will see is much more dominant as compared to the reasonable or relatively small left ventricle. So now we can probably see the opened up surface. Yeah. So now you can see here, this is what I mean by a very constant and a unique position of the ventricular septal defect. You can see the two bands of the trabeculoseptomarginalis which surround this defect. So this is the antero-superior band of the trabeculoseptomarginalis, and this is the postero-inferior band, and you can see that the ventricular septal defect is somewhere in between. And this is probably the outlet septum which has moved from its original position and has come anteriorly. And that is what causes probably the obstruction to the right ventricular outflow. You can see that this is the entire right ventricular outflow. This is the infundibular chamber which is lying just below the pulmonary valve. This is the pulmonary valve and the annulus which appears quite hypoplastic, and then this is the main pulmonary artery, and these are the branches of the pulmonary arteries which look relatively good. And you can see here that the right ventricle is pretty hypertrophied, which is a characteristic or hallmark of any form of tetralogy of Fallot, may it be only tetralogy or amounting to pulmonary atresia. Now let's see from the left side. So, you know, we may be able to see something more from the left side. So this is the left ventricle which is opened up, and as was shown to you in a normal heart, you see the left ventricular surface of the septum. It is a relatively smooth surface if you were to compare it with the right side of the heart, where you will find that there are coarse trabeculations. And now you will imagine that why some of the muscular VSDs in setting up of tetralogy can be completely missed or may be very difficult to find on table. You can see how hypertrophied this particular aspect of the interventricular septum is. Now if you see from the left ventricular aspect, so this is probably the ventricular septal defect lying here, and you can see that it just lies beneath the aortic valve, and that is the reason why many of the times you describe this ventricular septal defect as subaortic ventricular septal defect. So there are multiple terminologies which are used to describe this VSD. Just because it lies just underneath the aortic valve, you call it subaortic. Because there is a malalignment between the septal or the outlet septum and the muscular septum, you call it a malaligned VSD. Because it involves the conal septum, a conal portion of the interventricular septum, you call it a conoventricular septal defect. And it is a perimembranous defect because it is bounded or surrounded by the tricuspid valve at one end and the aortic valve at the other end. So these are the various terminologies which are used to describe this.
So I was taught by Jeong when he worked together in the one of the military hospital already 30-something years ago. But anyway, the way how I do is that I identify the diaphragmatic surface of the heart, which is usually flat. I use my left hand as diaphragm, and then on top of that I place the heart like this. Okay, so therefore this is the inferior aspect of the heart. So on the diaphragm, this is the right side, this is the left side, superior here, posterior here, and anterior here. So therefore, this is a levocardia. And then if I look at the atrium here, so as the Jeong showed in the previous normal anatomy, this is apparently triangular right atrial appendage here on the right side. And then the other side, this is the very, very classic, the finger-like crenellated, the tubular, the appendage with third orifice. So this is the classic morphologically left atrial appendage. So by atrial appendage morphology, it is apparently serous soletus. And then I need to look at whether the superior vena cava here and the inferior vena cava are really connected to the right atrium, which is the superior vena cava, inferior vena cava. You have your right atrium here, so there is normal systemic venous connection. And then turning the heart to the back, and then I can see that you open the left atrium here, and then to look at whether all the pulmonary veins connect to the left atrium. So apparently this is the orifice to the atrial appendage. This is not pulmonary vein. So however, this is the pulmonary vein orifice, and the other should be somewhere. Where are they? Sectional line, all along the sectional line, okay. So those are all included in the sections here. So anyway, pulmonary venous return is okay. So the atrial serous is normal with the systemic and normal systemic and pulmonary venous connections. And then open from examining from the right side of the heart, this is the opened, could you hold this one too? Yes, thank you. So this is open the right atrium and open the right ventricle here. And then this is the atrial part. This is the ventricular part. This is the septal leaflet of the tricuspid valve. And then in the atrial side, you have the fossa ovalis here with the superior limbus and inferior limbus. I don't see any atrial septal defect at all. Okay, and then coronary sinus is atrial, the anatomy is normal. Coming down to the ventricle, and then I now see the hole here. So as the Jeong showed, this is the inlet part of the right ventricle. This is the trabecular part of the right ventricle, and this is the outlet side of the right ventricle, and there is a hole involving the outlet side. How do I know? So this is a Y-shaped trabecular septum marginalis. So this is the body of the trabecular septum marginalis. This is the anterior limb of trabecular septum marginalis. This is the posterior limb of trabecular septum marginalis. And then you have the medial papillary muscle here, papillary muscle of Lancis here, which indicates this defect is definitely involving the outlet part of the ventricular septum. So if I look at the posterior margin of this VSD, it really goes all the way down to the tricuspid valve annulus, and then that is clearly defining that this VSD is the perimembranous VSD, mostly extending toward the outlet. Right? Yeah. Okay. Past one, the exam question. So, and then from there, let me go to the left ventricle before go to the great arterial trunk. So this is the open the left ventricle. So from the open the left atrium here, so mitral valve, anterior leaflet of the mitral valve is here. In contrast to the right ventricle, I don't see mitral this AV valve having any coral attachment to the septum. Anyway, the ventricular septal defect is here. I don't see any direct outlet from the left ventricle toward the great artery. So the only outlet of the left ventricle appears to be this, the ventricular septal defect. Okay, so. And then coming back to the right ventricle, then I need to identify two great arteries. So one is that in the right anterior aspect, the semilunar valve is here, and then apparently there is a coronary artery ostium there already. So which means that this is aorta, and then aorta is patched here, and then the other artery is behind. So this should be the pulmonary trunk, and then you have the left pulmonary artery. Right pulmonary artery, this is a PDA.
Right PDA.
Not PDA, okay. So this should be the PDA, right?
This one.
This one is, okay. So this is the RPA behind the aorta like this originally, okay. So this part is very difficult from the imaging, because the imaging never displaced in the pathology specimen. It can go anywhere. So anyway, so here that it is clear now that this whole thing is open right ventricle. You have aorta rising from here. This is the pulmonary trunk. Now VSD is immediately below the pulmonary valve here. So double aortic right ventricle with the subpulmonary VSD, and then this is the outlet septum, then a little bit distorted by previous observer or by the Dr. Saw. And this is the outlet septum, and then this outlet septum makes this aorta completely isolated from the location of the VSD here, so remote. And in this sense, that is not entirely true embryologically. It should normally like this, the closing the VSD, and is deviated leftward, rightward, forward, and superior, and then making this subaortic area significantly smaller. And then in fetal life, there is smaller amount of blood flow coming into the aorta. So therefore, that there is a high incidence of tubular hypoplasia of the aortic arch or coarctation of aorta, which is nicely shown here. So basically, all of this complex, cytosolitus, atrioventricular concurrent connection, the large perimembranous outlet VSD solely committed to the pulmonary valve, and then having various degree of aortic arch obstruction with or without significant subaortic stenosis, which is the pretty much classic Taussig Bing type of double aortic right ventricle.
In this particular specimen of DORV, it was very nice surgery done by Dr. Kim Woong-han, and he said the history why this patient died, and that this specimen shows the real pathology after operation. In this case, we can see very nicely see the ventricular the extracardiac valve conduit between right ventricle to pulmonary artery. So before he installed this this conduit, he made the BT shunt, to make this pulmonary artery bigger. So there was a two-step procedure. When he was an infant, he made a shunt from innominate artery to the right pulmonary artery. So there was a shunt between here to here, but now it is divided to make a final corrective surgery of this patient. So because at the beginning there was a tetralogy fellow with severe hypoplasia of pulmonary arteries, so he introduced this shunt and make pulmonary artery is bigger, and then now he could successfully make a the Rastelli operation with valve conduit between right ventricle to pulmonary artery, and then internally the defect is successfully closed with endothelioalized very smooth surface. So the operation and post-operative period was very very okay. So but in when we autopsy, we could realize that there was some whitening of left ventricular endocardial surface with some thinning of myocardium with some fibrosis within it. So it's a kind of ischemic result of left ventricle with some dilatation of left ventricle chamber. So we are expecting there is a minor degree of coronary artery insufficiency in this area. So so the operator says he should place this conduit not to this area but to this area, because of there are some significant coronary arteries around here. So he could place this conduit to close to the atrioventricular groove, but he thought there will be damage to at this area that yeah, it was the surgeon's observation that in this area there is a coronary artery partly sutured by some of the suture to make this conduit here. So maybe this coronary artery damage was very much minor to have this baby successfully operated and weaned from the after operation. But in the long-term effect of this minor the stitch to the coronary artery made this left ventricle ischemic and make her insufficient and could not have this longer survival in this patient. So that was the discussion with surgeon who operated this particular patient. And then we can compare these two specimens with Rastelli operation. And this case was the double outflow right ventricle with subaortic VSD. So it's a kind of severe form of tetralogy fallow. Yeah, it's a kind of tetralogy fallow with hypoplasia of pulmonary artery and so on. But in this case, the aorta was more to the anterior, and pulmonary artery was more to posterior. So the location of conduit in this case was not here, but in the close to the middle of the right ventricular surface. In this case, it's also very much damaged, but there was an intracardiac the baffle to close this area. So if to examine the original shape of the heart, we can remove this baffle to show there is an original position of pulmonary stenotic pulmonary artery here. So there is this case was again the tau saving heart with subpulmonary VSD from left side coming to here and go to pulmonary artery, and aorta is here. So but in this case the surgeon removed this outlet septum, and because the pulmonary artery is hypoplastic, he could cover all together to make this conduit go left ventricle to the aorta through this tunnel-like baffle. So it was also very successful, and endothelialization and everything was fine for a while, but there was a mortality. And then this is a extracardiac valve conduit. It is operation in 1983, so long time ago. So the the material may be different from the current use, but it was very successful. But the cause of death in this case, we thought that there was an embolism and thrombus in this internal surface of this conduit, having the pulmonary embolism from this case. And then we also realized that it was a very much difficult case for total correction, because the pulmonary artery is hyperplastic, but not that much hyperplastic. So the course of subaortic course from left ventricle to aorta is relatively long. So it's a really very good surgery, considering this difficult anatomy for good correction. And also, in this case, we can see the left ventricular surface, left ventricle with a mitral valve, and also some of the coda of mitral valve is attached to the anterior margin of this VSD, which is not definitely straddling, but it's a kind of minimal degree of straddling mitral valve in this case to make this abnormal attachment, this coda to the anterior margin of VSD. So, this abnormal attachment of this coda is an additional cause of subpulmonary, subaortic obstruction after surgery, and also the size of VSD was relatively good, but it's an after excision of some of the muscle here. So the surgery at that time tried very hard to make VSD bigger, considering this abnormal caudal attachment, and also to make this outlet septum between pulmonary and aorta narrower, and close this aortic pulmonary valve and make a single patch baffle to make this tunnel. So it's a nice example for DORV with subpulmonary VSD and Rastelli operation.
So because VSD is quite small and is partly is covered by the mitral valve, so I think it's not easy to fix that. I don't know, maybe the final option would be like single ventricular repair in this patient. But well, we need opinion from surgeon, of course. Well, if VSD is big and there's no obstruction, maybe we just go for like switch operation and Rastelli or whatsoever. I mean, switch operation and closure VSD as. Oh, is there any PS this patient? Yeah. Oh yes, there is. So then maybe just on hand. I mean, single ventricular repair.
How about I don't know, but the tricuspid valve, when the tricuspid valve prosthesis is straddled, it could be transferred. But this is mitral valve. So, Dr. Song, what do you think are the transferring the chordate to the not to make some obstruction at the VSD level in this patient, because it's very, very difficult anatomy?
I think it's very difficult. Maybe I think the surgeon should. I think the surgeon did the extension of VSD at the time of operation. Yeah. Maybe if the patient had a pulmonary stenosis, there is the switch operation could not be the option. So I think all we can do is to enlarge the VSD. But I think maybe the surgeon did not know the left side morphology, so he did enlargement VSD as possible as large as possible. So I think that is the only way. Yeah. And besides that, I think all we can do is univentricular repair only. Mm. But I think that is a very, very bad option.
So we know that the operation field does not have this exposure, so it's very hard to recognize, but still the surgeon may have recognized this, the anteriorly attached caudal structure through this VSD. So he dissected only to apical side of myocardium, and the basal part is not possible because of the conduction is going around here, and also the caudal attachment tricuspid valve, the upper side is difficult because the mitral attachment.
Right, yeah.
So
Right.
it's,
Maybe
so
I think this is a very unique case.
Yeah.
Usually it is possible to enlarge the VSD, the excise the ventral septum anterior superiorly. So no problem with that. But in this case, maybe I think when if we did the enlarge big enough, it might be there might be some big injury in mitral valve. So it can cause the catastrophe, maybe.
Yeah, so in this case, it was very difficult situation, but in 1983, the surgeon did really very good operation in this patient, and the left
I think so,
yeah,
yeah.
left ventricle has enough myocardial structure. That means there is no problem for coronary arteries, and also left ventricular function is good enough to make this operation very successful. Although the post-operative management of this thrombotic phenomenon in this area. So now if your current surgeons in here can make the same operation, he will still survive.
I have a question. Is any cardiologist can give information about the mitral valve, abnormal attachment of mitral valve to the surgeon? Can you do that? In echocardiography? Also, that is very important at point. But I think if you can do that, we have to consider to enlarge the VSD very carefully.
This type of mitral valve straddling is quite a unique feature of some ToF being abnormalities. And then the literature describes that usually anterior and posterior papillary muscles are there in the usual location, and straddling is usually third accessory papillary muscle. So here that in the left ventricle, I see that anterior and posterior papillary muscles quite nicely arranged, right? But the straddling overriding part of the mitral valve is through separate chordae, correct? So
the mitral valve truly straddling the septum? I don't think so.
No, it is the coda tendinae is at least going on the top of the ventricular septal crest.
Yeah, it's going
Yes.
on the crest.
So it is almost that here is straddling the toward. Yes.
Grade one
Yeah.
straddling.
Yeah.
So it is if it is the top of the crest, if it is a little bit towards the right ventricle, that is theoretically and the straddling. It's pretty much that if you don't agree with straddling, it is the next to that top type of disease. That's why that the surgeon was not able to really enlarge that. In the right ventricle side, I think at the 1 or 2 o'clock side, there is a tension apparatus from the mitral valve, correct?
So
From
the
yeah.
usual shape of mitral valve in this view is because the septum is here,
Yeah.
this part is not attached here, but this is okay, but this is not okay. So anterior mitral leaflet should have this kind of size and shape around here to make this VSD freely open to not attach to any caudal structure of mitral valve, but is open just underneath the pulmonary valve. So this is definitely abnormal structure. So even though this is not also the other papillary muscle, but it's if we can say make a really normal papillary muscle structure, I would place this papillary muscle to here, to make here, and make this mitral valve from here to here. So there's it's a kind of a cleft mitral valve in here to have this abnormal cleft with short caudal attachment near to the VSD.
This is the right, and this is the left side, and apex and base, this is the superior aspect of the heart. First of all, according to segmental analysis, I will see the arrangement of atrial appendage. So this is the right side atrial appendage with a broad base with a triangle shape. It would be possible. This is the right atrial appendage. But the most common thing is to check the internal structure of the right atrium, the pectinate muscle. Okay, the pectinate muscle extends all around the right AV junction. This is definitely the important feature of right atrial appendage. And then we can see left side atrial appendage. So a little bit broad base, but I'm not sure from this external structure of the right atrial structure, but I'm going to again check the pectinate muscle pattern. Of course, in this atrium, the pectinate muscle extends all around the AV junction, so we can say that this appendage is morphologically right atrium. So atrial arrangement is the isomerism of right isomerism, right?
Yeah.
Okay. And then I'm going to look at the thoracic structure, lung. This patient had 1, 2, 3 lobes of lung. This is the morphology of right lung. And then again, left lung has the, okay, 3 lobes of left lung also. This is the morphology feature of left atrium. So then again, I'm going to check the bronchus pattern of this patient. This is trachea and carina. It's left main bronchus and right main bronchus. This patient has bilaterally short main bronchus. That indicates that this visceral cytosis is right isomerism, you know. So and then again, I'm going to check the systemic venous connection. This should be the superior vena cava connected to the right atrium. And then again, we have abnormal vascular structure drained to the SVC. So I'm going to follow this structure. Okay, from back. This is the SVC and abnormal vessel drained to the SVC. I'm going to follow this abnormal vessel. It's connected to the lung. So this vasculature must be the pulmonary veins, right? So in this case, all pulmonary veins join together to the vertical vein and drain into the right SVC. This is case of total anomalous pulmonary venous return. As I say, this is the left-sided morphological right atrial appendage. Have another abnormal vascular structure drained to this chamber, right?
Yeah.
So this must be the left SVC,
Yeah.
I think. So very complex heart. And I'm going to move to the aorta. This is the great artery arising from anterior part of the ventricle, very big, and has the orifice of the coronary sinus. This must be the aorta. And branching pattern, you can see this is the first branch to the left side and have the 2 branches here. So this arch must be right aortic arch. And then, okay. But where is the pulmonary artery? So I'm not sure, but you can trace the lung once again. This should be the main pulmonary artery to the ventricular mass, connected to the ventricular mass. But, okay, in the internal structure. So, as I mentioned, this patient has the isomerism right atrial appendage and connected to ventricular chamber with common AV valve. Okay, so this is common AV valve. Okay. And this left-sided chamber has a fine traffic relation. And so it must be the morphologically left ventricle, but quite small. And this is the right ventricle. So this patient has the right isomerism, common AV connection.
I want to make the two comments in this case. One is that the supracardiac type of the TAPVC or PAPVC in the presence of right isomerism, the usual location of that connection is retrobronchial. In right isomerism, either on the right side or left side. In left isomerism, it is not retrobronchial, but in right isomerism, it is usually retrobronchial, as I mentioned briefly. And the second is that when you have one large ventricle and one small ventricle, in the context of the double inlet ventricle or absent AV valve connection, the easiest way to define the ventricular morphology is the location of a small chamber relative to crux cordis. So if you see the small ventricle posterior inferior and then right the adjacent either on the right side or left side at the corner of crux cordis, that is automatically left ventricle, and that the other is right ventricle. And then rudimentary chamber of right ventricular morphology never is posterior inferior. I wouldn't say never, because you can have a reception, but Bob Anderson agreed that he didn't see anything. Tentatively speaking, that Bob Anderson agreed that this rule is almost 100%. When I asked his opinion, so right ventricle is away from the crux cordis if it is rudimentary, and then if it is rudimentary, left ventricle is always at the corner of crux cordis. That's the value of identifying crux cordis in this single ventricle morphology. When they're talking about supracardiac type, the anatomical vice location. That anatomical vice location is actually between the pulmonary artery and then the ligamentum ductus, and then posteriorly pulmonary artery. So you have three vascular structures making a sort of a spatial triangle, which is in the cytosolitis, left pulmonary artery, left ductus, and the left pulmonary artery makes a small space between these three vessels. And then that is the area where the anatomical vice happens.
Okay, this is the left pulmonary artery. This is left main bronchus. If the vertical vein goes between these two structures, making severe obstruction, so this is the anatomic vice, right? Okay.